Respected teachers, dear colleagues and learned audience, good afternoon. Me, Dr. Priyanka Poddar, welcoming all in today's webinar. Our scientific partner, SA Pharmaceuticals, brand partner, Ovazal Biocal-D, and media partner, Raj TV. PCOS is one of the leading problems in our women of all age groups. It's an also important case for our postgraduate students and our day-to-day practice. So our today's topic of live webinar is PCOS. We are very glad to inform you that we have got two renowned professors as our panel of experts. They are Professor Dr. Begum Nasrin, Professor of and Gynae Department of Bangabandhu Sheikh Mujib Medical University. And our another panel of experts is Professor Dr. Jasmine Banu, Chairman Department of Reproductive Endocrinology and Infertility, Bangabandhu Sheikh Mujib Medical University. Our today's discussed topics are Professor Dr. Begum Nasrin Madam discussed about pathophysiology of PCOS and update, and our another panel, Professor Dr. Jasmine Banu Madam, will be discussed about infertility and PCOS. I like to request our all learned audience that they make questions in our comment box, so we'll be glad. Now I would like to invite Dr. Faria Afrin to present her case regarding PCOS. Dr. Faria Afrin.
Thank you, Priyanka Poddarapu, for inviting me here. Assalamu alaikum, respected panel of experts and dear audience. I am Dr. Fariha Afrin, FCPS Part 2 course student of BSMMU of Department of Obstetrics and Gynecology. Welcome you all in today's webinar case presentation section. Today's webinar topic is polycystic ovarian syndrome, which can be presented in various decades of age with various clinical manifestations. My patient is a reproductive age lady. Now let's see what is her complaints and manifestation. Now I am showing my presentation. My patient, Mrs. Nahar Akhtar, 34 years of old age lady, a Naliparas housewife belonging to a middle-class family hailing from Jatrabari, got herself admitted in Reproductive Endocrinology and Infertility Department of BSMMU on 19 February 2020 with the complaints of wants to conceive for 6 years and infrequent menstruation since menarche. According to the statement of the patient, she is married for 7 years. After marriage, she took OCP for 1 year. Since then, they are living together without any contraceptive method but fail to conceive. Their coital practice is regular at a frequency of 2 to 3 times per week, and she gave no history of dyspareunia. She had her menarche at 12 years of age. Her cycle is infrequent, occurs at an interval of 5 to 6 months and persists for 9 to 10 days with average flow and sometimes with scanty blood flow. 5 years back, she had 8 months of amenorrhea that was followed by heavy menstrual bleeding. Since then, she was frequently on and off on tablet norethistérone for control of continuous vaginal bleeding. She gives no history of dysmenorrhea. Her last menstruation period was 13 December on 2019. She noticed excessive hair growth on her upper lip and chin for last 3 years, and she did plucking for cosmetic purpose. Also gave history of gradual weight gain, that is 12 kg, for last 3 years. She gives no history of cold intolerance or lethargy or deepening of voice. She is normotensive and non-diabetic. She gives no history of tuberculosis or any surgery. Also, she gives no family history of diabetes mellitus, hypertension, or any such diseases. Her husband is a 39 years old aged service holder. He is also non-smoker, no history of alcohol or drug abuse. He is non-diabetic, normotensive, and gives no significant history of mumps, tuberculosis, or exposure of sexually transmitted disease. She did not underwent any surgery around his genital tract. He is normogynous. With these complaints, she attended a gynecologist 2 years back and advised to took ovulation-inducing drugs, that is letrozole, for 6 cycles, which she did not follow up after 3 cycles. Now she got herself admitted to REI Department of PSMMU for further management. Now comes to clinical examination. Doing general physical examination with due consent and maintaining adequate privacy, I found her cooperative. Her height at that time was 155 cm and weight 78 kg. Accordingly, BMI 32 kg per meter square body surface area. Her pulse was 82 per minute and BP 110 over 80 mm of mercury. Core temperature of body was normal, that is 98.4 degree Fahrenheit. Acanthosis nigricans present on nape of the neck, axilla, and inner thigh. Hirsutism present on upper lip and chin. She was not anemic, not icteric, non-edematous. There was no galacturia and thyroid gland was not enlarged. Both breasts were normal. No accessible lymph nodes were palpable. Cardiorespiratory system showed no abnormalities. Doing para-abdominal examination on inspection, I found central obesity was present, and during palpation, abdomen was soft and non-tender. Her waist circumference was 106 cm and waist-hip ratio was 0.84. Vaginal examination on inspection showed vulva perineum introitus apparently healthy, except acanthosis nigricans present on inner thigh. Perispiculum examination showed cervix was nulliparous and apparently healthy. Bimanual examination showed uterus was normal in size, mobile, and inverted, fornices were free and non-tender. So, from history and clinical examination, my provisional diagnosis is this is a case of primary subfertility with chronic anovulation, possibly due to polycystic ovarian syndrome. That's all from my case side. Thank you all.
Thanks Dr. Faria for your beautiful case presentation. Now I would like to invite Professor Begum Nasrin Kiron Madam to present her case regarding pathophysiology of polycystic ovarian syndrome and update.
Thank you, Priyanka. This is Dr. Begum Nasrin, Professor, Department of Obs and Gynae, Bangabandhu Sheikh Mujib Medical University. Today, the topic of my presentation is pathophysiology of Pcos. Pcos is an ancient disorder. Now, today, my lecture covers the etiology, incidence, diagnostic criteria, pathophysiology, clinical presentations, subtypes of Pcos, morbidities of Pcos, and summary. Initially, Pcos was described in 1935 by Stein and Leventhal, and it is redefined in 2003 by American European Society of Reproductive Medicine. Though it is a very common disorder, frequently faced by obstetrician and infertility specialist, actual cause is basically unknown. But there are some links associated with the Pcos, and there is also some scientific basis, and there is some evidences that genetic factors are related with the Pcos. What are the genetic causes? There's the mode of inheritance is abnormal. There is mutation of P450 gene, mutation in the insulin receptor gene. There is familial predisposition, and it is found that Pcos has been proved to be a familial condition. It runs in first-degree relatives. Autosomal, there is some association of autosomal dominant inheritance and with variable penetrance in the females. 50% chance of offspring are being affected. Phenotype manifestation itself via raised androgen excreted by the ovarian theca cell. Severity seems to be determined by the factors such as obesity. There are some racial variation also. It is more common among the Southeast Asian and among rice eater than European and American community. It is there is heterogeneous mode of presentation, various modes of presentation, and lack of specific clinical or endocrine criteria for diagnosis of the disease. PCO may be associated with hirsutism, acanthosis nigricans, obesity, polycystic ovary, subfertility, and hyperprolactinemia. But all these features may not be found at a time. It is found that there is evidence that chronic low-grade inflammation has emerged as a key contributor to PCOS. A dietary trigger such as glucose is capable of inciting oxidative stress and inflammatory response in PCO women. Now, immunological factor. Women with PCOS present with hyperestrogenic stress will stimulate overstimulation of the immune system. Now, regarding statistics, it is in UK it is found that 15 to 25% UK women are affected, but 50% of UK Asian women are affected. South Asian women present at younger age and often have more severe symptoms. In Indian, in a journal it is published, in Indian Asian urban community, this number is more and seems to be rising for reason which is not known. 30 to 30 in this study it is found that 30 to 36% girls in India are suffering from PCOS. Now, diagnostic criteria. NIH, National Institute of Health, in 1990, in a consensus workshop, suggested that a person has PCO if they have all the followings, that is oligoovulation and sign of androgen excess, either clinical or biochemical. But they suggest that we have to exclude other disorder that can cause menstrual irregularity and hyperandrogenism. Other cause has to be excluded. In 2003, Rotterdam criteria, in a consensus, they redefined PCOS, and they defined as any two of the three following criteria should be present for the diagnosis of the PCO. What are that? Oligoovulation or anovulation, clinical or biochemical evidence of hyperandrogenism, and polycystic ovary on ultrasonogram. Any two, if any two of these three present, they defined it as PCOS. Now, Androgen Access PCOS Society in 2006 they redefined PCOS. According to them, hyper must be present. Hyperandrogenism, either clinical or biochemical, must be present, and ovarian dysfunction like oligo anovulation and or PCO by TPS ultrasonogram. According to this criteria, hyperandrogen must present, and anyone must have to be present, either oligo or anovulation or polycystic ovary. In this case also they suggested exclusion of other androgen excess related disorder. Now, what are the criteria of PCO? When we say polycystic ovary by seeing TBS or TBS ultrasonogram, ovaries are enlarged, volume have to be more than or equal to 10 cubic centimeter, stroma are increased, become more echogenic, that is stromal hyperditis due to hyperphagocytosis of stroma, and multiple follicle, that is more than or equal to 12 follicle is measuring about 2 to 9 millimeter in diameter, are mostly found or crowded around the cortex. It is called the necklace pattern. Here you can see two pictures here. The follicle are arranged in necklace pattern, mainly in the cortex. Now, if we summarize in one page, then what we have described already, NIH, both the symptoms must be present. hyperandrogenism, and menstrual irregularity, that is anovulation or oligovulation. Rotterdam criteria, any two of the three things: hyperandrogenism, menstrual irregularity, polycystic ovary. And androgen excess PCOS society, they must present hyperandrogenism and any one either menstrual irregularity or polycystic ovary. Now come to my point, that is pathophysiology, today's point of discussion. Despite being one of the most common endocrinopathy, principal molecular defect that causes PCO is lacking. Heterogeneity of PCO reflects multiple pathophysiological mechanisms. It may be genetic, environmental, or multifactorial. All the factors may act at the same time. Traditionally, PCO is considered as the result of a vicious cycle which can be initiated at any one of the many entry points. Altered function at any point in the cycle leads to the same result. Several theories have been proposed to explain the pathophysiogenesis of PCOS. Evidence shows that there is association between the cytochrome P450, 17 hydroxylase, and 17 and 20 desmolase and PCOS. There is also association between cytochrome P450 side chain cleavage enzyme and PCOS. These are published in the journal, a reputed journal. Now, the principal target, where in which point there is alteration. There is alteration in gonadotropin secretion, insulin secretion, androgen biosynthesis, and ultimately there is change in the weight and energy regulation. This is the hypothalamic pituitary. This is a normal hypothalamic pituitary ovarian axis. We have to know first the basic normal physiology. Then we will try to know the pathology. Here there is hypothalamus. From hypothalamus, GnRH is released. This GnRH stimulate the anterior pituitary to secrete FSH and LH. And mainly here FSH is more than LH. And this FSH act on the ovary, and there is folliculogenesis, ovum is released, and there is estrogen and progesterone released from the ovary, and these estrogen progesterone again act on the endometrium and cause change in the endometrium, and there is menstruation. And there is some negative feedback mechanism. If estrogen is high, it negatively inhibit the FSH level. This is the normal hypothalamic pituitary ovarian axis for regulation of the ovulation and menstruation. Now, what happened in the PCOS? You can see here is the hypothalamus. This is the pituitary, and we know that hypothalamus release GnRH in pulsatile manner, but in PCOS there is this pulsatile pattern of GnRH release is disturbed, and as a result, pituitary is stimulated to produce FSH and LH, but here mainly LH is produced in large amount than FSH, and as a result there is more LH compared to FSH. And we know FSH is the main hormone which stimulates the ovary to cause ovulation and then menstruation. But here what happens, here there is FSH is low, so it cannot stimulate the ovary, and LH is high. LH act on the ovary, that they mainly the thicker cell and stimulate the thicker cell to release androgen. There is high level of androgen then and this is one mechanism. I will tell you the insulin in the other slide. This androgen act on the skin. There is here it causes hirsutism, acne, acanthosis nigricans, etc. I want to switch to the next slide and for other mechanism to describe. LH increased compared to FSH. LH, here it is seen that LH action enhances in the ovarian level. Ovarian receptor are overexpressed. All hormone act through and receptor, and LH receptor are overexpressed on the thicker cell. follicular arrest and increased androgen production. Follicular arrest occur, I have already told that FSH release is insufficient, so they cannot stimulate the follicle to develop up to dominant follicle. So the follicular development are arrested. On the other hand, LH stimulate thicker cell, and there is increased production of androgen. As a whole, what is the result? There is anovulation. Anovulation. FSH is suppressed by negative feedback mechanism of estradiol. If there is high estradiol, it negatively, then it gives signal no need of FSH. So FSH release is decreased. But just we can concentrate here. That's the last part of the slide. Here pituitary released LH and FSH. Here there is increased estradiol. Of many follicle produce estradiol, that are many follicle ovulation is not occurring, no progesterone, only estrogen is produced. Increased estradiol and increased androgen. This is positively, there is positive feedback mechanism on pituitary, further stimulate is LH. And estradiol, increased estradiol and increased insulin negatively feedback pituitary, and there is decreased FSH secretion. Now, insulin. There is we all know that in PCOS there is insulin resistance. So how it act on what is the mechanism of action of insulin secretion, and what are the pathology here? I am going to describe it in detail. Insulin secretion and its action. Insulin resistance appear to be related to the mutation of the insulin receptor gene. Mutation on the insulin receptor, the insulin is released from the islets of Langerhans, but it acts through the receptor, but receptor is defective, so it cannot act on the target tissue. Okay, now that so it cannot function. Insulin cannot function it properly. Insulin mainly act on the glucose, and glucose is stored as glycogen and in the liver and skeletal muscle. So insulin cannot act properly, and there is hyperinsulinemia, and in 50 to 70% PCO patients have insulin resistance. Insulin, it is present but it cannot act. So this condition is called insulin resistance. Insulin resistance cause hyperandrogenism. How? Insulin inhibit the hepatic sex hormone binding globulin production. Hyperinsulinemia inhibit liver to secrete sex hormone binding globulin. As a result, hyperinsulinemia and LH synergistically stimulate the theca cell. In one side, inhibit the liver to inhibit the production of sex hormone binding globulin. On the other hand, hyperinsulinemia and LH synergistically stimulate theca cell to secrete androgen. As a result, there is a high androgen and high free testosterone or androgen. As we know that if there is less sex hormone binding globulin, there is free testosterone level is high. So, what are the causes of high androgen? Several mechanisms are there. Defective GnRH pulse, increase LH. LH stimulate theca cell, stimulate the theca cell to release androgen. Insulin and androgen again stimulate the liver to decrease hepatic sex hormone binding globulin. As a result, total result of this is increased free testosterone level in the circulation. This is insulin resistance, high insulin, high testosterone, androgenic effect in the body like hirsutism, acne, and other androgenic biochemical and clinical feature of hyperandrogenism. Here, insulin inhibits sex hormone binding globulin. Insulin is present, but it cannot act. So, blood sugar level become high, altered metabolism, fat, storage of fat in the body, and body weight. There is weight gain. Now, there is a pictorial slide. This is the gene. Here, there is a mutation in the production of the GnRH analog, GnRH. the altered GnRS function. GnRS stimulate the pituitary. Pituitary release high LH, and LH, in case LH stimulate the theca cell. Insulin, here there is pancreas, insulin is secreted, but it cannot act. There is it cannot, insulin naturally normally it causes the act on the glucose and store it in the liver and skeletal muscle, but here it cannot act, so there is hyperglycemia. Insulin blood sugar level rise, and there is increased risk of IGT and diabetes mellitus. There is altered metabolism of in this insulin cannot act on the glucose. There is altered metabolism, and there is free fatty acid in the blood, and ultimately stored in the body and muscle, and patient develop obesities. Now the clinical presentation, how a PCO patient present. I have already told that their clinical picture, they present as heterogeneously. Some patients present with menstrual irregularities, some are overweight, patient may present with hirsutism, acne, patient come to you with fertility issue, pre-diabetes, diabetes, early onset type 2 diabetes mellitus, and these patients ultimately develop depression, anxiety, sleep disorder, etc. Now, what are the common menstrual problem? Among the menstrual problem, irregular means fewer than 8 menstruation in a cycle, or no means at all. 87% of the women were present with oligomenorrhea, 26% of women present with amenorrhea. Sometimes they present with heavy menstrual bleeding. And then infertility, 50% of them present with infertility. It is found that infertility is 10 times more common among the PCOS patient. Now, hyperandrogenism related symptoms, this is hirsutism. More than 70% of patients with PCO grow hair in their face and body. Acne, male hormone can make a skin oily, and weight gain. Up to 80% of the women with PCO are overweight or obese. Male pattern baldness, darkening of the skin, dark patches of the skin can form in the body, crease like in the neck, groin, under the breast, etc. This is the picture. You can see here that acne, hirsutism, and alopecia, male type baldness develop. Obese, this is acne. This is the sonographic, this is a laparoscopic picture of ovary, pearl white, thick capsule, no sign of ovulation, larger size. And in the, if you do TVS, we can see the necklace pattern, follicle, large, many small follicle, mainly arranged in the cortical part of the ovary, and thick size of the ovary is enlarged, and theca stroma are hyperechogenic and increase in size. Now, I have here summarized the hyperandrogenism feature. Hyperandrogenism feature. I already have told that clinical examination we can find hirsutism, acne, alopecia, acne. This is the clinical feature of hyperandrogenism. Lab value, biochemical value, high testosterone and estradiol. Menstrual irregularity I have already told. Oligomenorrhea, amenorrhea, and high luteinizing hormone. PCO I have already mentioned this. Now subtype of the PCO. In PCO, we have told that the LH level is high and insulin level also is high. Some patient is insulin driven, and some patient present as LH driven symptom. We have this this stimulate more, and in some patient insulin resistance is more. LH driven patient are slim, they have high LH, high impaired GTT, response to ovarian diathermy. এটা এখন করা হয় না, এক সময় ওভারিতে আমরা ডিলিং করতাম, এখন এটাকে আরো অনেক যেহেতু ড্রাগ চলে আসছে সেই ক্ষেত্রে আমরা ডায়াথার্মিটা একটু অ্যাভয়েড করার চেষ্টা করি। আচ্ছা ইনসুলিন ড্রিভেন যেগুলো থাকে সেগুলো থাকে সেন্ট্রাল ওবেসিটি থাকে এই পেশেন্টগুলোর অ্যাকান্থোসিস নাইগ্রাকান্স থাকে এবং লঙ্গার ইন্টারমিনিস্ট্রাল ইন্টারভাল অলিগোমিনোরিয়া টাইপের মিনিস্ট্রাল প্যাটার্নটা বেশি থাকে। এখন ফিনোটাইপ এখানে বলছে যে রোটারডাম ক্রাইটেরিয়াতে দেয়ার আর 4 phenotype classic polycystic ovary. Here there is chronic anovulation, hyperandrogenism and polycystic ovary. All these three are present. Classic non-polycystic ovary, chronic anovulation, hyperandrogenism present, but ovaries is normal. Non-classic ovulatory PCO, here regular menstrual cycle, but there is hyperandrogenism and polycystic ovary. And last one is non-classic mild normoandrogenic PCO. Here there is chronic anovulation, normal androgen level and polycystic ovaries. Now what are the long-term risks associated with the PCOS? There is many morbidities associated with the PCO patient. I have already told that obesity, in the different studies it is shown that obesity 60 to 76% patients suffer from obesity. Type 2 diabetes 1 in 5 patients. Cardiovascular disease 7 times higher risk of MI. Endometrial carcinoma PCO have threefold increased risk of developing endometrial cancer. Now metabolic syndrome. Morbidities of PCO, one of the important morbidities is metabolic syndrome. A cluster of conditions like high blood pressure, high blood sugar, abnormal cholesterol or triglyceride level significantly increase the risk of cardiovascular disease. High blood pressure, high blood sugar and all cholesterol level is high. All this accumulate to increase the risk of cardiovascular syndrome. Non-alcoholic steatohepatitis, severe inflammation in the liver and fat accumulation in the liver and fatty liver. Initially we think that fatty liver is a normal condition, but now it is established that if fatty liver is severe, it causes cirrhosis of liver. And ultimately it may develop liver cancer. Other morbidities associated with sleep apnea, depression, anxiety, eating disorder. Now I have shown some reference here. In this reference there are many reference, but I have shown you one or two several study using এখানে দেখা গেছে intima and medial thickness টা বেড়ে যাচ্ছে এবং cardiovascular risk টা বেড়ে যাচ্ছে, potential increase cardiovascular risk in the women with PCOS. এখানে calcification, similar study using coronary artery calcification, as this stratification has shown increased risk of patient with PCOS, sleep apnea and other sleep disorder. Multiple group has documented an increased risk of sleep apnea and other sleep disorder in patients with PCOS. Body image and quality of life in PCO patient. There is little study of the psychopathology of the woman defined as having PCO in literature, but obesity and infertility cause greatest degree of stresses, and many conditions coexist PCO such as pelvic pain, depression, altered mood, but it is unclear scientifically whether they are causal or they are associated with PCOS. Now let's summarize these things. What I have already told. Here there is genetic factor and lifestyle factor. Which is the cause or which is the effect, we do not know. There is a vicious cycle. Genetic factor affect generation along insulin resistance, and high LH as a result androgen level high. It causes hirsutism, acne, psychological issue is there. FSH level is less, LH high, so ovulation cannot occur, and there is anovulation, high estrogen, and menstrual irregularity, oligomenorrhea, amenorrhea, sometimes heavy menstrual bleeding. And for metabolic syndrome, there is insulin resistant, the patient become diabetic, hypertensive, metabolic syndrome, cardiovascular risk, and ultimately patient develop depression and anxiety. That's all. Thank you all.
Thanks, Professor Begum Nasrin Madam, for your valuable presentation. It will be helpful to our all postgraduate students and as all of us also. Now I would like to invite our another panel of experts, Professor Jasmine Banu Madam, to present her presentation regarding infertility and PCOS, how to manage.
Thank you, Dr. Priyanka, for the nice moderation, and thank you. I also thanks Dr. Faria and Professor Kiran for her nice presentation. And now I highlighted about the infertility and PCOS, the how to manage. And the infertility, PCOS is a very common endocrine disorder in reproductive age women. PCOS is one of the most common and treated cause of the infertility. And more than half of the PCOS develop due to diabetes mellitus before the age of the 40 years. Development of the other medical conditions such as the insulin-resistant type 2 diabetes mellitus and metabolic syndrome and cardiovascular disease and also the endometrial carcinoma develop as a long-term health hazard of the PCOS. Now, the natural history of the PCOS, that is started from the fetal life and it transmitted through the adolescent, childbearing age, and menopause, and also the post-menopause. And it started the fetal life and the premature, and when they go to the adolescence, that presented with the premature adrenarche, clinical hyperandrogenism, and when it's present with the childbearing age, it presented with infertility and the irregular menstruation. And in the menopause and the post-menopause, they also develop as a metabolic syndrome, that is the diabetes mellitus, dyslipidemia, blood pressure, and the obesity. And in case of the post-menopause, they present the cardiovascular disease and endometrial carcinoma and also the breast cancer. And now, what are the factors affecting the PCOS and the infertility? The most common factor, that is the genetic predisposition, which aggravate the PCOS and causes the infertility by increasing the testosterone level and by the insulin resistance and produce the anovulation and produce the infertility. Next, what are the other factors affecting the infertility? That is by the immune system alteration and by the accumulation of the toxin and bad dietary habits and due to the genetic incidence and as well as the insulin resistance and obesity. All of the factors encourage the PCOS and after effect is the infertility. And now the oxidative stress is called the infertility. How the oxidative stress causes the PCOS and how its effect and causes the infertility. We know that the well established that is a oxidative stress occur in the PCOS. How that there is a imbalance between the oxidant and the pro-oxidant and the antioxidant and produce the large number of the oxidative stress. And this oxidative stress causes the oocyte maturation defective and granulocyte cell utilization is defective. So thereby poor quality of the oocyte development and the progesterone production is the less and the luteal phase is defective and thereby resulting the infertility. And the oxidative stress is affect the lifestyle factor, that is the obesity, undernutrition, recreational drug, alcohol, cigarette, and environmental factor. All these factors causing the oxidative stress and effect of these oxidative stress produce the PCOS and some other gynecological disorders such as the endometriosis, preeclampsia, age-related fertility decline, and there is unexplained infertility. And after affecting the childbearing, when they are pregnant and their oxidative state affect and causes the IUGR, preterm delivery, and the spontaneous abortion. Ongoing stress. There is some ongoing stress and which causes the polycystic ovarian syndrome. These ongoing stresses affect the increased cortisol level secretion, and this increased cortisol raises the insulin production, and these high level of the insulin production imbalance in the causing the insulin resistance and causing the PCOS and thereby the infertility. Now, Dr. Professor Kiran already said that is the phenotypical classification of the PCOS, and that classified the PCOS at the Rotterdam consensus, that is the newer classification, that is the mild, moderate, and the severe PCOS. when there is a mild PCOS and it is only the oligovulation, anovulation and polycystic ovary are present. But when there is a all three are present, that is the oligovulation, anovulation or hyperandrogenism and polycystic ovary, all three are present, then we call that is the severe PCOS. And when the present the oligovulation and the hyperandrogenism but no PCOS, that is the moderate PCOS. And moderate PCOS are the two types, that is the ovulatory and the anovulatory. When the anovulatory, there is the presence of the hyperandrogenism and there is a presence of the oligovulation. But in the ovulatory PCOS, hyperandrogenism present and there is a polycystic ovary but no anovulation. So it is called the ovulatory PCOS. So the moderate PCOS are two types, that is the ovulatory PCOS and anovulatory PCOS. And other are the severe PCOS and hence the mild PCOS. Now, what are the impact of the PCOS on the fertility? And the PCOS effect on the fertility, they lead to the anovulation, and the PCOS when the ovulate in the 25% cases and the woman present with the anovulation at the 75% cases. And this PCOS impact on the fertility, that there is the production of the infrequent menstruation and there is a recurrent pregnancy loss, and the effect of the PCOS, the patient suffering from the diabetes mellitus and also the hypertension, preeclampsia and the premature delivery. So all these things are effect of the PCOS and effect on the fertility. And how they causes the infertility. That is, it produces the infrequent menstruation and by the anovulation. And infrequent menstruation is by the impact of the PCOS, that is it causes the follicular arrest. And there is no mature follicular developed due to the hormonal imbalance. And there is no ovulation occur, and that is the oligomenorrhea and amenorrhea and resulting the infertility. And the ovulation disorder is due to the high androgen and the high testosterone level and the no development of the mature follicle. And it also developed the recurrent pregnancy loss. At least the 25 to 44% patient of the PCOS are suffering from the recurrent pregnancy loss due to the insulin resistance and resulting the diabetes mellitus. And the and also the recurrent pregnancy loss is due to the inadequate production and deletion of the endometrial and the endometrial preparation is lacking. And there is a chronic inflammation. Low-grade inflammation occurs. This low-grade inflammation at the vegetable oil, spicy fluid, ghee fluid, and the sugar and the overproduction of the androgen. And how the PCOS causes the chronic anovulation. And there is a secretion of the dopamine, opioid and serotonin, all are decreased, and GABA is the increase. So thereby the imbalance between the neurotransmitter. This neurotransmitter imbalance, so there is a high LH level. This high LH level causes the hyperandrogenism and insulin resistance and thereby the chronic anovulation. And the impact of the obesity on the PCOS. And the PCOS is struggling with the infertility and the patient are the obese, and that by result the insulin resistance, and there is a secretion or the decreased secretion of the sex hormone binding globulin and increased androgen level and thereby anovulation. In the obese patient, 10% have the undiagnosed diabetes and there is a 35% have the IGT. And obesity adversely affect the reproduction, that is the anovulation, pregnancy loss, and the late pregnancy complication. And one study shows that the obesity in patient with the PCOS, and there is the thin PCOS, and two type of the PCOS, thin and the obese. And the obese PCOS, there is a decreased sensitivity of the insulin, and so there is a anovulation is the more, and there is a more anovulation. And when there is a lean PCO, there is a insulin sensitivity is the good, so there is a decreased insulin resistance and there is a less production of the less produce the anovulation. And hyperandrogenism, a chronic anovulation. Next. Next, hyperandrogenic anovulation. And due to the high LH stimulation in the PCOS and excessive production of the aromatase enzyme, there is an androgen breakdown to produce the estrogen. And then estrogen causes the negative feedback effect of the hypothalamo pituitary axis, and there is a decreased secretion of the ovarian follicle and thereby decreased sensitivity of the FSH. So there is a no mature follicular develop, and there is produces the anovulation. And the role of the AMH and the effect of the PCOS, and thereby the resulting the infertility. At the high AMH level, in case of the PCOS, due to the there is a small and preantral and the large antral follicle, and there is a more immature follicle, and the more immature follicle are produced the more AMH, and this more AMH suppress the inhibin B, increase the inhibin B, and these high level of the inhibin B, which also suppress the FSH on the hypothalamus and pituitary. So there is a FSH is the low, and these FSH is the low, and at least at the antral follicular present, and so the up to the 8 to 12 millimeter of the follicle the develop as the PCOS patient because of this high inhibin B and the low FSH level. So thereby the no development of the preovulatory and the ovulatory follicle. So in relation with the AMH and the PCOS and infertility, is there is a low development of the low developing follicle due to the high AMH level. And here is the effect of the PCO on the endometrial dysfunction. PCOS also causes the endometrial dysfunction, and there is resulting the infertility. And the low luteal phase occur due to the low progesterone, we know all, but there is some glycogen and the insulin-like growth factor binding protein also low, and endothelin level is the high in the PCOS cases, and there is a inadequate blood flow, endometrial blood flow. So all these things prevents the implantation of the embryo, so thereby the chance of infertility is the more. And although induce the hyperinsulinemia in case of the PCOS, and there is resulting the decreased blood flow, and the progesterone phase is the defect. So no progesterone is developed, and progesterone phase is the luteal phase is the defect. So there is the all this endometrial dysfunction and causes the PCOS infertility. And what is the relation of the ovarian reserve and the PCOS? And there is a two type of the PCOS, and that is the young PCOS and the aged PCOS. And the young PCOS is the more vulnerable to effect of the infertility, because in young PCOS there is a more follicular growth, preantral and the antral follicle is the more, and there is an increased production of the inhibin B and the AMH from the antral follicle. So there is a suppression of the FSH, and there is FSH is lower, and the anovulation occur in case of the young PCOS is the more. But in case of the aged PCOS, there is a follicular growth is the decrease, because aging PCOS, there is a cohort follicle is lower, and so the lower cohort follicle and the preantral follicle and the antral follicle is the low, and so the inhibin B and AMH level is also decreased, and due to the decrease in inhibin B and AMH level, there is an increased chance of the FSH secretion, and so this increased chance of the FSH secretion causes the follicular maturation, and there is the ovulation occur. So it is the young PCOS, aging PCOS is better than the young PCOS in relation with the fertility, and there is a chance of the ovulation in aging PCOS is possible, but rather than the young PCOS. Now the diagnosis, how we diagnose the PCOS and how we manage the infertility patient. And Dr. Professor Kiran already says there is a 3 criteria, and the androgen axis nice and the algorithm criteria. We overlook this slide. And now the PCOS is diagnosis by the or no by the history examination and by the investigation. And history, the symptom already is discussed, and now we go for the investigation. And there are, before we going for the investigation, we some part we highlighted that there is a next slide, go please, and highlighted that is the percentage of the next slide, and percentage of the PCOS presentation according to the presentation. And there is a infertility PCOS patient are 75% are presented with the infertility. So it is the most common part of the PCOS presentation, and thereby the presentation is the hirsutism, and amenorrhea is the only 50%, and obesity is also the 30 to 50%, and UB is the 25%, and presentation, and these are the according to the presentation of the PCOS. And now the diagnosis by the investigation. Before we going for the investigation, it's the disease of the know that there is a disease of the exclusion. Before we diagnose the PCO, we exclude the other cause of the anovulation and other cause of the androgen excess, and exclude the insulin resistance and exclude the metabolic syndrome. So these four things are already diagnosed when after the exclusion of the anovulation and after the exclusion of the androgen excess, we go for the diagnosis of the polycystic ovarian syndrome. And when it is associated with the sign symptom of the hyperinsulinemia and the androgen excess, then we go for the diagnosis of the insulin resistance. And when it is go for the other feature of the complication of the PCOS, that is the diabetes and hypertension, and there is a hyperlipidemia, and this diagnosis is the case of the metabolic syndrome, then we go for the investigation for the metabolic syndrome. Now the investigation, that is the hormonal profile. First of all, we do the transvaginal sonography and findings, that is the polycystic ovary. And we diagnose the polycystic ovary by the transvaginal sonography. And when the menstrual irregularities, and there is when amenorrhea more than 6 months, then we do the transvaginal sonography to exclude the endometrial hyperplasia. And thereafter we go for the hormonal profile. The hormonal profile exclude the other cause of the anovulation, that is the FSH and LH ratio. When the LH ratio is the more and the FSH ratio is the more than 2, that is the higher LH level, and we predict that this is the higher risk of the miscarriage. And there is the high TSH level, and the TSH level is the more than 2.5 is the predictor. That is the some criteria for the anovulation and infertility. And there's the serum prolactin, whether that is the hyperprolactinemia present or not. And there is the associated investigation. We do the AMH level, not necessary for all the patient, but because it reflects the morphology and it is not a diagnostic factor, it is a predictor of the PCOS, and so it needs to manage the patient, and in case of the future management, and needs the AMH level to challenge the diagnosis of the PCOS. And we first exclude the anovulation by hormonal analysis, and secondly, we exclude the androgen excess. Androgen excess, this androgen excess presented with the adrenal tumor, androgen secreting tumor of the ovary, and the late onset of the congenital adrenal hyperplasia, and also the Cushing syndrome. So when there is a other cause of the hirsutism and acne is excluded, then we diagnosed that it is a polycystic ovarian syndrome, hyperandrogenemia due to polycystic ovarian syndrome. So the adrenal tumor we exclude by the when the there is a sign symptom of the rapid growing of the hirsutism, and dihydroepiandrosterone sulfate is the 700 to 800 microgram per dl. Then we go for the diagnosis of the adrenal tumor, suspected case of the adrenal tumor, and then we do the ultrasonogram of the whole abdomen and the CT scan to exclude this. And when there is a testosterone level, the patient presented with the rapid hirsutism, and there is oligomenorrhea, amenorrhea, and the presentation, and then rapid onset of the hirsutism, then we go for the excessive and rapid, go for the testosterone level. And when the testosterone level is the 150 milligram per day more DL more, then we diagnosed a case of androgen producing tumor. And when there is a rapid onset and severely progressive growth of the hirsutism, and there is a sign of realization, that is that cryptomegaly, depending on the voice, is also present and associated with the oligomenorrhea, amenorrhea, then we diagnosed a case of late onset adrenal hyperplasia rather than the polycystic ovarian syndrome. So then we do the 17 alpha hydroxyprogesterone day 2 morning sample. And when the 17 alpha hydroxyprogesterone level is more than 200, that is the suspicious, and it is more than 700 nanogram, then it is the diagnostic. So the if it is between the 200 to 700, then it is the suspicious case of the congenital adrenal hyperplasia, and then we do the ACTase stimulation test for the confirmation. And now the Cushing syndrome, and there is a presence of the estrous central obesity and the low potassium level and the high basal cortisol level and the high androgen level to exclude the Cushing syndrome. So for the diagnosis, we exclude the anovulation, then we exclude the adrenal tumor, androgen secreting tumor, late onset congenital adrenal hyperplasia and Cushing syndrome. Also for the diagnosis of the Pcos, but not all the patient. When that patient are criteria for this and the presentation are such type of presentation present, then we go for this investigation. Now the insulin resistance, and when patient presented with the when patient presented with the insulin resistance sign symptom of the hyperinsulinemia, then we do the investigation for the insulin resistance. And how we diagnose that is the insulin resistance. That when the patient body mass index is more than 25 and waist is ratio is the more than 0.85, presence of acanthosis nigricans and the Heron syndrome. When the patient presented this type of symptom, then we screen for the insulin resistance test, IR index, and for the test of the androgen level. Then routine screening of the insulin resistance is not, an index test is not recommended. And the screening of the IR is recommended when the androgen level is the more than 150 nanogram per DL and the clinically suspected in such type of feature. Then we go for the screening for the insulin resistance. And how we diagnose that it is the insulin resistance. That is we go for the investigation with the OGTT. If the OGTT is the impaired and hemoglobin A1C is the more than 6.5 and the fasting insulin level is the more than 20 international unit per ml, then we call for it is the hyperinsulinemia. And then we do the glucose insulin ratio, that is for the insulin resistance. Insulin glucose ratio is less than 4.5. That indicates the insulin sensitivity is the decrease. And then we go for the HOMA-IR index. And HOMA-IR index, when the presence of the patient at the clinically suspected the insulin resistant feature and there is a presence of the hyperinsulinemia, then we'll go for the HOMA-IR index. And HOMA-IR index is the glucose millimole per liter plus the insulin milli-international unit per ml divided by the 22.5. We calculate the HOMA-IR, and the HOMA-IR index is the value less than 1 is the normal, but suspicious when the HOMA-IR index is the more than 2. And the HOMA-IR index is the possibility of the insulin resistance is the when the HOMA-IR index is the more than 2.5. But it is the HOMA-IR index is the more than 5, that it is the insulin resistance and called the diabetes mellitus. And now the metabolic syndrome. And this metabolic syndrome is not a routine diagnostic test for the PCOS diagnosis. And when the patient presented with the insulin resistance and there is some feature of the metabolic syndrome, then we go for the further test and to exclusion the metabolic syndrome. And there's the criteria for the metabolic syndrome. There is only 5 symptoms and there is a more than 2 symptoms are the present, that is called the metabolic syndrome. That is the waist hip ratio more than 0.85, increased blood pressure more than 150 by 80 millimeter of the mercury, and triglyceride level more than 150, and HDL level is the less than 50 milligram per DL, and fasting glucose level is more than 100 milligram per DL, or previously established diabetes mellitus. And in case of the PCOS patient, 10% presented with the IGT and 30 to 40% presented with the diabetes mellitus. So the screening of the IGT can help the early diagnosis of the insulin resistance. If there is a IGT but a hyperinsulinemia, and then we possible early diagnosis of the insulin resistance by the insulin index, and it prevents the GTM when the patient becomes the pregnant, and long-term complication is also prevented by the early screening of the IGT. Now I am going for the management. Next slide, I am going for the management. Next slide, next, and I am going for the management. And the management is the multidisciplinary approach, that is the PCOS appearance, a form of the different type of presentation. So that due to this management, there is a multidisciplinary approach is recommended. When the patient presented with the hyperandrogenemia, acne and hirsutism, that consult with the dermatologist and the endocrinologist. When they suspected with the insulin-resistant hyperinsulinemia and diabetes mellitus, also consulted with the dermatologist and endocrinologist. And in the menstrual disorder, oligovulation, infertility, and then presented and consult with the gynecologist. And there is a infertility and worsen the follicular quality, and there is an infertility specialist, and I consult with the IVF specialist. And there is a psychological problem, and depression is also present in the PCOS patient, so that needs the help of the psychologist. And now looking for the comorbidities of the PCOS before the treatment of the infertility. What are the comorbidities? And when the patient are presented with the infertility, but there are some comorbidities. So first of all, we treated the comorbidities of the patient and simultaneously treated the infertility. Comorbidities, there is a patient presented with the central obesity, hirsutism, acne, diabetes, high blood pressure, cholesterol abnormality, hypothyroidism, and hyperprolactinemia. So all these things are treated in the simultaneously. And now the PCOS infertility treatment by the first of all by the lifestyle modification, then the drug, then surgery, and by the ART. First of all, the lifestyle modification. In the PCOS, the infertility due to anovulation and the normal semen parameter and the tubal patency test should be discussed in the individual basis. After the tubal patency test should be considered prior to the ovulation induction in women with the PCOS where there is a suspected case of the tubal infertility. And now the treatment modalities are the lifestyle modification, then the medical treatment, and third option is the third line of treatment is the surgical treatment and the ART. So the first of all, there is the lifestyle modification, and there is some smoking cessation and advice for the decreased alcohol consumption is highly recommended. And the medical treatment is there is a maybe the option at the OCP therapy, anti-androgen therapy, ovulation induction drug, and there is the insulin sensitizing drug. And the surgical management by the ovarian drilling, laparoscopic ovarian drilling, or the bariatric surgery may sometimes needed. And ART is included the ovulation induction with the IUI and also the IVF. Now the lifestyle modification in the obese patient, and the lifestyle modification, at least we already discussed the alcohol consumption is decreased and smoking is inhibited and diet control, and also the physical activity is the increases, and also there is the pharmacological weight loss drug are some as necessary, and some bariatric surgery is also useful for the weight loss. And the 5 to 10% of the weight loss help to regular ovulation and improve the chance of the pregnancy. So how we exercise, causing the patient lifestyle modification by the exercise. Exercise increasing the physical activities, and by recommended the exercise is the 30 minutes of the moderate exercise it in the 3 times per week. Daily 30 minutes on alternate day, the 30 minutes in the 3 times per week. And this is the recommended exercise. And the diet, there is a hypocaloric diet, and the 500 kilocalorie is the deficit per day. And the reduced glycemic control and the low carbohydrate diet is necessary. So the diet and exercise are essential part of the lifestyle modification and the weight reduction. And there are some fertility friendly drug tips of the foods, and there is a total consumption is usually needed the 800 calorie, that is the 500 calories the discarded. And there is a now a recent study, there is a 90 days study, that is the 3 months is resistant. There is a big breakfast group and the big dinner group, whose are the beneficial. The big breakfast group always there is a 980 kilocalorie diet for is consumption, and the big dinner group there is the 980 kilocalorie big dinner group. But when the big breakfast group 980 kilocalorie is the beta reduction of the insulin and the testosterone level, so that there is a 50% rise of the ovulation rate. So there is this study showing that the big breakfast is the better than the big dinner group. So the big breakfast is the fertility friendly eating tips of the polycystic ovarian syndrome. So the big breakfast is there is a more vegetables and the more protein diet, and there is a low carbohydrate and low fat diet is also showing the pictorial presentation of the fertility friendly tips of the PCOS and the big breakfast group. Now the 10 foods are avoided in the PCOS diet. So there is a refined carbohydrate, breads, pastas, sugar are also avoided, and food that is in sodium and the packaging food is also avoided. Fried food avoided, fruit juice avoided, and there's some the red meat is the avoided, and the consumption of the red meat is low, and the saturated fat is also curtailed from the diet. And is also use the lifestyle modification and the weight exercise, and thereafter use the anti-obesity drug to reduce the obesity. And there is the anti-obesity drug is considered the experimental therapy in women with the PCOS for the improving the fertility, and risk and benefit ratio is the uncertain. Though there is a early state is the anti-obesity drug, sometimes they use in the when there is a all other method as the failed. Now we come for the ovulation induction in fertility treatment. And the ovulation induction, previously slide we know that there is a classical PCOS, anovulatory PCOS, and ovulatory PCOS. That is the classical means the all 3 types are present, that is the severe PCOS, and anovulatory and ovulatory PCOS, that is the moderate PCOS. And this is the type 2 anovulation. WHO type 2 anovulation, and this WHO type 2 anovulation is managed by the ovulation inducing drug, and the aim is the ovulation induction is the single tone like birth and the limited number of the developing follicle, because there is the more chance of the developing follicle, that more chance of the hyperstimulation syndrome. So it is prevented by the cautiously use of the ovulation inducing drug and limited number of the developing follicle. At first line of therapy is the recommended the clomiphene citrate, and the recommended clomiphene citrate improving the fertility, and unfortunately it is not successful for the everyone. So there is a 25% having the clomiphene resistance and not response to the fertility. And there is a how the mechanism of the clomiphene resistance is clomiphene citrate act, and clomiphene citrates block the estrogen receptor of the hypothalamus and thereby decrease secretion of the FSH and LH. So there is a more secretion of the there is a block the hypothalamic estrogenic receptor, there is a more secretion of the FSH and LH. There is a more increased follicular development in the circulate and increased circulating estrogen, and hypothalamus resulting in the positive feedback surge. And these FSH and estrogen is the positive feedback surge, and there is a production of the LH. So there is a FSH surge, and LH surge is also by the clomiphene citrate. So there is the ovulation. And 20% patient having the clomiphene resistant, not response to the clomiphene citrate, that is called the clomiphene resistant. When the failure to ovulate after 3 cycle of the clomiphene citrate consecutive cycle with the 150 milligram of the clomiphene, but fail to ovulate, that is called the clomiphene resistance. And clomiphene failure when the patient ovulate but not the pregnancy in the 3 ovulatory cycle, and that is called the clomiphene failure. So the clomiphene resistance and clomiphene failure, we go for the next option. And what are the causes of the clomiphene resistance? There is a clomiphene resistance. Next slide. Next slide. Next slide. Next slide. Next slide. Next slide. And the clomiphene resistance, causes of the clomiphene resistance, that is the genetic and the high level of the dihydroepiandrosterone sulfate, and the patient's the BMI is the more than 25, and the hyperprolactinemia. And these are the causes of the clomiphene resistance. That is that all patients are not response to the clomiphene, not sensitive to the clomiphene due to these conditions. When the patient weight is more, when the patient associated with the hyperprolactinemia, when the patient has some genetic cause and hyperandrogenic feature, so this patient not response to the clomiphene, and that is called the clomiphene resistance. And then we go for the treatment of the clomiphene resistance. And when there is a clomiphene resistant patient, next option is there is the clomiphene resistant with the metformin. And the clomiphene resistant, and what are the other use? And we use the metformin in case of the clomiphene resistant. But what are the other use of the metformin? When the Pcos patient with the IGT, then we use the metformin. And the patient with the pre-treatment of the Pcos, when the patient needs the IVF, then we go for the pre-treatment of the Pcos patient before the IVF. So it is the another use of the metformin. And when the patient is the Pcos, is suffering from the RPL, and there is the patient associated with the IGT, then we go for the metformin. And when there is a patient with the history of the hyperstimulation syndrome in previous IVF cycle, then with the treatment with the metformin. And is all the use of the metformin. And only insulin resistant patient and the patient with the IGT, we also use the metformin. But the study found that the combination of the CC and the metformin would the most beneficial in the CC resistant patient, not all the patient we go for the metformin. In case of the CC resistant patient, that is the Cochrane review in the 2012. Another study shows that there is no support the use of the metformin. They discourage the metformin as a first line of the therapy in the Berry in the ATL in the 2018. For those with the hyperprolactinemia, the treatment with the drug of the bromocriptine, either in the clomiphene citrate or with the alone, in the improve the ovulation rate. When the clomiphene resistance is due to the hyperprolactinemia, then we combine with the bromocriptine use. Next, the aromatase inhibitor. Next drug of the ovulation inducing, that is the aromatase. And this is the now clomiphene citrate is not randomly used, and the aromatase inhibitor is now the first line of the treatment. And because the clomiphene citrate is not respond on the clomiphene citrate, and some women with the unexplained infertility, then we will go for the aromatase inhibitor. And there is an advantage, that is the over the clomiphene citrate, that there is a less likely develop the multiple pregnancy. And how they work? And the aromatase inhibitor, this is the enzyme aromatase are inhibited, so there is a decreased conversion of the androgen to the estrogen, and these hypoestrogenic state release the negative feedback effect of the hypothalamus to the estrogen, so thereby increase secretion of the gonadotropin and increase secretion of the follicular development and the increased follicular maturation, and there is a more follicular development, and there is a only monofollicular development occurring the aromatase inhibitor, because specifically sensitive to the specific follicle by the FSAs. And endocrine societies are recommended that there is a we use the clomiphene or plus the gonadotropin or the letrozole. That is that there's a study showing that the letrozole is the better than the clomiphene plus 2 doses of the gonadotropin. That is the ovulation occurred in the only letrozole group 79.3% and the clomiphene and the 2 doses of the gonadotropin and the ovulate is the 57%. And there is the pregnancy rate are found that there is a 23% pregnancy in the letrozole group and only 14% pregnancy in clomid and the clomiphene citrate and the low dose of the gonadotropin stimulation. So there is the letrozole alone is better than the clomiphene and leads to the gonadotropin stimulation is the endocrine societies that recommended. And now the gonadotropin. Gonadotropin is the evidence-based care research in the 2016 and 17 showing that the gonadotropin should be the second line of treatment. And the first line is the oral medication. In case of the anovulatory infertility, when there is a clomiphene citrate resistance and there is no other fertility factor. So we then go for the there is a 6 cycle of the next slide. There is a gonadotropin is the clomiphene citrate resistance and other anovulatory factor. Other factors are absent. And before we prescribe the gonadotropin, some consideration should be some consideration in mind that there is a availability of the ultrasound monitoring. If there is no ultrasound monitoring, so we not go for the gonadotropin stimulation, and there is a expertise is needed for the dose and the drug bioavailability expertise is the needed, and the following counseling and the cost of the gonadotropin is also recommended before the uses, and there is a risk of the multiple pregnancy in the gonadotropin uses. So all these things are counseling the patient before prescribe the gonadotropin stimulation. Now the two main type of the gonadotropin preparation are used in the ovulation induction, that is the urinary gonadotropin and recombinant gonadotropin. Urinary gonadotropin, there is a HMG and highly purified HMG, purified FSAs and highly purified FSAs and urinary HCG. But now in the recent study, there is a recent use is the recombinant FSAs, recombinant LH and recombinant HCG. So we're showing the manogon, that is the recombinant manogon, that is the FSAs, and LH, that is the HMG, urinary HMG, and FSAs only, that is the recombinant FSAs, that is the recombinant FSAs, that is the recombinant FSAs. And now when we do the trigger, and after the gonadotropin stimulation, there is the, in case of the gonadotropin stimulation, some difficulties we consider already discussed, and there is a triggering is also in mind. There is a low grade stimulation protocol should be considered to optimize the monofollicular development, and trigger is the trigger will be done when there is a less than 3 follicles are present. Then we go for the trigger. And if there is a more than 2 mature follicles are present in case of the Pcos, then we stop the gonadotropin, and then we stop the triggering of the Pcos, triggering of the patient, and that advice for the unprotected coitus. Because there is a chance of the hyperstimulation syndrome when there is a more than 2 or more than 3 mature follicle at the present. So there is a, when there is a more than 3 follicle present, there will not given the trigger, that is the ECG injection, and not try for the pregnancy. And because of there is a multiple pregnancy, and they avoid the multiple pregnancy. Now the pre-treatment. And the pre-treatment before the ovulation induction is essential. In some condition, when there is a clomiphene resistant patient and there is a high level of the dihydroepiandrosterone level and there is a androgenic feature are present, and so we give the birth control pill for the 1 to 2 months. Thereafter go for the ovulation induction, whether it is the CCA or aromatase inhibitor or by the gonadotropin. When patient presented with the hyperandrogenemia and there is insulin, there is the presence of the CC resistance, we go for the birth control pill. Either it is the anti-androgen or it is the combined oral contraceptive pill. And it seems to be by counter initiative, the birth control pill help to get the pregnancy. Yes, there is some study. One study, the use of the birth control pill over the 65% clomiphene resistant women at the ovulate by the pre-treatment with the 2 cycle of the OCP and then followed by the ovulation induction, and the 65% patient are ovulate in the CC resistant. Now the treatment of the hirsutism and the Pcos. And the hirsutism is patient presented with the hirsutism and treated with the combined oral contraceptive pill or by the androgen. Anti-androgen. Anti-androgen reduces the excessive hair growth by the androgen production, decreases the androgen production. And other drug are they use the spironolactone and the eflornithine. Spironolactone is also block the androgen production. And when there is a contraception is required, and then the spironolactone should not be used, not recommended. And the eflornithine is a cream and it used for the facial hair, and it acts to take time to act in the 6 to 8 weeks. But it disadvantage that the hair will reappear after stopping the treatment. And the other option of the hirsutism, that is the electrolysis and the primary cosmetic, that is the shaping, waxing, and the depilation of the epilation of the hair follicle. And now the laser therapy is required for the long-term treatment and the more successful in the women with the dry skin. And the management of the menstrual dysfunction due to PCO disorder. When there is a PCO is presented with the menstrual dysfunction, first line treatment is a patient with the obese and diet and lifestyle modification. Then we go for the combined oral contraceptive pill or the cyproterone acetate anti-androgen. But in case of the patient is more than 35 or morbidly obese or the smoker, and then avoid the OCP. And in these cases, the Mirena is used as an alternative in case of the abnormal menstruation dysfunction with the PCOS. And when the patient not to consume the pill, then we go for the cyclical progesterone, and there may be a role of the metformin. But in case of the endometrial hyperplasia, it will be due to the endometrial hyperplasia but no desire for the pregnancy, then you'll go for the endometrial resection. And with all these things are for the menstrual dysfunction in the PCOS. And then now the menstrual dysfunction due to PCO disorder, but patient desire for the pregnancy. Then you go for the, not for the OCP, not for the anti-androgen, and you go for the progesterone. And the infrequent menstruation or the withdrawal bleeding may be progesterone, followed by the ovulation induction in the treatment of the choice. And there is a hyperandrogenism, but is the now a recent study when the patient with the menstrual dysfunction and there is a feature of the hyperandrogenism, but patient wants to conceive. So there is a pre-treatment with the cyproterone acetate followed by the ovulation induction is the treatment of the choice. And if there is a more than 6 months, there is a oligomenorrhea, severe, or the amenorrhea, and there's the present with the chronic anovulation, then we go for the progesterone derivatives. Now the surgical treatment. Surgical treatment is the go for the polycystic ovarian syndrome is the laparoscopic ovarian drilling. But not all patients go for the laparoscopic ovarian drilling. There is some indication when we go for the laparoscopic ovarian drilling. That is the when the patient is the high LH level or the ovarian volume is the more than 15 cc and there is increase in androgen level and patients are suffering from the chloroquine, citrate and all medical treatment at the failed. And previous history of the ovarian hyperstimulation syndrome in ovulation induction with the gonadotropin, and patient having the recurrent pregnancy loss due to PCOS and other ovulatory factor not respond to the medical treatment. In this condition, we go for the laparoscopic ovarian drilling. And that should be considered in LOD, something to be considered. That is the considered, that is comparative cost should be considered, and the expertise is required for the LOD, and the intraoperative and the post-operative risk is the more in the overweight obese Pcos patient. And there is a small risk of the low ovarian reserve due to loss of ovarian function due to the LOD, and there is some adhesion formation is associated with the risk. But there is a two school of thought, that is the LOD versus gonadotropin. Which one is the best? That is the LOD is the better than the gonadotropin stimulation in such condition. That is the LOD is the no risk of the ovarian hyperstimulation syndrome. So there is a patient when the GNT there is a hyperstimulation syndrome or the IVF there is a hyperstimulation syndrome and the patient suffer from the recurrent pregnancy loss and then go for the LOD. And we it is advantage that there is a no chance of the intense monitoring is the required. But in case of the GNT, there is the more chance of the monitoring is the required, and there is a single treatment of the beneficial for the 6 to 12 months in case of the LOD. But there is a monthly treatment is necessary for the gonadotropin. So LOD is the better in this respect than the gonadotropin. And the following ovarian drilling, ovulation is often restored for the 6 to 12 months, and ovulation increases 30 to 90% and pregnancy increases 80% in case of the ovarian drilling. So LOD is the better than the GNT. And now the bariatric surgery. When the lifestyle change is the failed and the patient are the morbidly obese, then we go for the bariatric surgery in some particular condition. It is not a quick option for the improving the fertility because the 12-month for stable for after surgery needs the 12 months for the stable. So at that time, patient not become the pregnant. So there is a risk of the some perinatal risk. So there is a, if the patient are treated with the bariatric surgery, they may be patient become stable for the 12 months. Thereafter, for the pregnancy, and there is a small for gestational age, premature is the infant mortality is the more, and but there is some potential benefit, that is the reduce the chance of the gestational diabetes and reduce the chance of loss of the gestational age. Now the ERT and the PCOS is the third line of the treatment. That is the ovulation induction, and after the ovulation induction, the failure, then we go for the ovulation induction with IUI when there is associated with the male factor and there is a failed ovulation induction. And the treatment, and there is a other fallopian tube at the open and the sperm count of the normal, then we go for the ovulation induction with the IUI. Typical success of the IUI is 15 to 25%, and the one individual success rate of the IUI is impacted on her age, and 50 to 25% are success rate. And now go for the IVF. And IVF is the PCOS patient is the great challenge. So there is a selection of the PCOS patient with the IVF is the most critical, and there is a pre-IVF workup is essential, and the rational use of the protocol, stimulation protocol, should be used in the rationally, and the gonadotropin dose is the titration. Gonadotropin dose is the use, and also mind that there is the prevention of the hyperstimulation syndrome is our objective in the IVF treatment. And the early treatment and the early and the late hyperstimulation syndrome is preventable by the early treatment. And there is a chance of increased risk of the cycle cancellation, and there is a chance of increased risk of spontaneous pregnancy also consideration. In that, all are the challenging in the IVF in the cycle in the PCOS. Now the IVF, when the ovulation induction and time intercourse and the 4 to 6 cycle of the IUI are failed, and one fallopian tube at the blocked, and a blocked fallopian tube, and then you recommended for the third line of the treatment, that is the IVF. And the objective of the IVF is to minimize the ovarian hyperstimulation syndrome, and to minimize the ovarian hyperstimulation syndrome by the transferring the small number of the embryo, the single embryo is the transfer, or there is a optimum stimulation protocol, that is the low dose stimulation protocol should be used, and there is a GnRH antagonist protocol, it should be used rather than the GnRH agonist protocol. And all these things should be mind, and that should be considered before using the stimulation protocol in the IVF patient. And there is a pregnancy rate is the similar to the PCOS in whether there is a multifollicular development, but there is a pregnancy rate is similar to the non-PCOS patient due to there is a chance of the multifollicular development, so there is a cancellation of the cycle is more in case of the PCOS patient, and there is a limited ovarian response occur, so there is a cycle cancellation occur, so there is the non-PCOS pregnancy rate are similar to with the non-PCOS patient. Now the doses of the gonadotropin are used in the IVF patient. There is the use of the low dose protocol. So we are starting the gonadotropin in the low dose, that is the 75 international unit per day, and the duration is the 5 to 7 days, and the no follicle are present, so there is a then we increases the dose up to the 50%, and there is a FSH serum FSH level, recombinant FSH level are used in the stimulation protocol, but recombinant LAs is not used in case of the IVF cycle. Now the GnRH agonist protocol, there is a pre-treatment with the metformin. In case of the GnRH agonist protocol, improve the clinical pregnancy rate. You already discussed that one study shows that is the metformin is pre-treatment with the metformin improve the clinical pregnancy rate and improve the clinical pregnancy rate per transfer in the IVF transfer. So the metformin is one of the pre-treatment in the IVF protocol. And there is a management option in the high responder. We will know that is the PCO patient are greatly with the higher responder, and this higher responder patient there is a estrogen level is the more than 3000, and there you go for the cycle cancellation. And the cycle cancellation, there is the GnRH agonist treatment. What is the cycle cancellation or the costing? That is the GnRH agonist treatment should be the continue, and the gonadotropin stimulation are stopped for the 1 to 3 days, and administration of the estradiol level at the moderate. Next slide, and the estradiol level are more, so the cycle cancellation occur. And preceding the oocyte retrieval and fertilization of the frozen embryo are transferred in case of the post high responder patient, and delay the transfer up to the 5 days after oocyte retrieval and prevent the OSAs. And this is the agonist protocol in case of the IVF cycle, and GnRH antagonist protocol. GnRH antagonist protocol is also adjusted with the metformin treatment and triggering by the, in case of the GnRH agonist protocol, triggering by the agonist not by the HCG. And now the recent advancement of the treatment in the IVF in PCOS patient, there is the IBM, that is the in vitro maturation the oocyte, and thereby the frozen the embryo, and thereby frozen the embryo, and then frozen embryo transfer in the next cycle. And pre-treatment with the OCP is the most beneficial. And that is the antagonist protocol. And that is the showing that the triggering by the GnRH or by the HCG, there is the comparison study showing that the GnRH agonist, triggering by the GnRH agonist, more the live birth rate and more the cumulative pregnancy rate in case of the GnRH triggering. And next slide. And some recent drugs are used in the treatment of the PCOS patient with the fertility. And some drug, that is the melatonin, one of the drug is used now recently. That melatonin decreases the oxidative stress, and there is the final maturation of the oocyte, and there is the O causing the ovulation. So newer drug is the melatonin, and one of the drug for helping the ovulation. And other newer drug, that is the N-acetylcysteine, myoinositol, N-methylfolate, and the alpha-calcidolyl. All are the newer drug in the help the decrease the insulin, increase the insulin sensitivity, decrease the testosterone level, and increase the follicular maturation. So and also the alpha-calcidolyl is the vitamin D. When there is a vitamin D deficiency and produce the insulin resistance and hyperandrogenemia. So improve the insulin secretion by the vitamin D supplementation. All these drugs are newly added. And our BSMMO now recently thesis work, research work in all these newer drugs. So we are waiting for the result of the newer drug research work in the BSMMO REI department. And the myoinositol is the one of the studies showing that there is a ovulation occur more, and there is insulin sensitivity is also increased by the myoinositol. And routinely we evaluated all these things, that there is a how we exclude the patient and how we treated the patient in a flow chart. After exclusion of the etiology of the anovulation and the hyperandrogenism, for the exclusion, we go for the FSH, LH, prolactin stasis, and the lipid profile. And if needed, we go for the insulin resistance investigation. And then we go for the infertility exclusion, that is the male factor exclusion, tubal patency test, and if needed, the hysterosalpingography to exclude the abnormalities of the uterine cavity. Then we go for the management, that is the, if there is the patient are obese, they go for the lifestyle modification, and there is the anovulation, we check the CC or aromatase inhibitor with the 6 cycle. If the CC resistant, then the aromatase inhibitor resistant, then go for the laparoscopy or the operant drilling or gonadotropin stimulation for the 6 cycle, plus minus IUI. And if the 4 to 6 cycle IUI are failed, then we go for the ART. And this is the one way for the management of the infertility in a flow chart. And now some are the deficiency factor of the multinutrient and vitamins, and which causes the infertility. And we already discussed, that is the ongoing research work in the REI department, that is the myoinositol versus myoinositol and the metformin in combination of myoinositol and the metformin. And another is the most important issue, that is the melatonin is the newer drug in the subfertile patient are used for the ovulation induction, is showing the biochemical response and outcome. And the melatonin is also the decreases the oxidative stress and increases the ovulation. And another important ongoing research, that is the pre-treatment with the cyproton acetate in case of the patient with the high AMH level, and there is reduces the high MS level and responsiveness of the letrozole is increases. So comparison with the letrozole and the cyproton acetate with the ethylene estradiol is the pre-treatment. And another important research work is also the kisspeptin in the PCOS. And there are other two research work is already going, that is the combination of the letrozole and CC versus letrozole, and another is the extended letrozole protocol versus the short protocol, and we are waiting for all these the result of the ongoing research, and we are hopeful for all these things. That is the recent study and the recent treatment protocol we are arranged by this study. Now the take-home message, PCOS is one of the most common disorder affecting the women of the reproductive age, improving the fertility in the primary goal of therapy. All women diagnosed with the PCOS should be screened thyroid disease, hypoprolactinemia, and the non-classical congenital adrenal hyperplasia. All women diagnosed with the PCOS should be screened the type 2 diabetes mellitus and the metabolic abnormalities. Maintaining the healthy active lifestyle decreases the infertility, and the first line of treatment is the ovulation induction after the lifestyle modification, and the appropriate ovulation induction is the highly effective, and the cumulative pregnancy rate is the 72%. And in case of the clomiphene resistant patient, generalized agonist and combined with the HMG is the essential. And another, the third line of treatment is the laparoscopic ovarian drilling. The second line of treatment when the other medical treatment is the failed. And third line of treatment is the recommended IVF, is the effective in women with the PCOS. And the use of the single embryo transfer and frozen embryo transfer is undergoing IVF, reduces the chance of the multiple pregnancy. And thank you all. And now is the September is the PCOS awareness month, so we go for the PCOS awareness in this month and the PCOS. And thank you all the patient sharing. কি প্রিয়াঙ্কা সবাই কি চলে এসেছে? হ্যালো 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 হ্যালো
Thanks, madam, for your valuable discussion.
সবাই কি চলে এসেছে?
না ম্যাডাম, আমরা সবাই আছি ম্যাডাম।
সবাই আছি, আমি ভাবতেছি যে এতক্ষণ ধরে সবাই চলে গেল কিনা।
Thanks, madam, for your valuable discussion. Now is the time of panel discussion.
শোনো, একটু ইন্টারফেয়ার করি, আজান দিয়ে দিয়েছে তো আজকের মতো শেষ করে দাও। আর প্যানেল ডিসকাশনটা আমরা পরে কোনো এক সময় আমরা আবার এটা নিয়ে আলাপ করতে পারবো, ঠিক আছে?
ওকে ম্যাডাম, ওকে ম্যাডাম,
চলে গেছে, আজকের মতো শেষ করে দাও।
ওকে ম্যাডাম।
হ্যাঁ, কোশ্চেন থাকলে আমরা পরে আবার করে নিব, মর্নিং সেশনে কভার করে দেব।
শোনা যাচ্ছে না কেন?
হ্যাঁ, তোমার কথা আমরা শুনতে পাচ্ছি।
Thanks, madam, for your valuable time. Thanks, ACI, to arrange this webinar in pandemic situation so that we can update our knowledge all the time. Thanks our learned audience for your patience hearing and making interactive by questions. And last but not the least, thanks our case presenter, Dr. Faria. Thanks our renowned panelists, Professor Kiran madam and Professor Jasmine madam for your valuable time.
Thank you all.
Thank you প্রিয়াঙ্কা। আজকে হলো যে আজকে তো ভিভি ডিসকাশন হয়েছে, ডেসক্রিপশন হয়েছে। আমরা মনে করো পরে আরেকটা সময় একটা জাস্ট কেস ডিসকাশন করতে পারি, একটা কেস বা দুইটা কেস নিয়ে, সেটা পরে
মর্নিং সেশনে ওগুলা যখন মর্নিং সেশন হবে না, মর্নিং সেশনের সময় এরকম কেস নিয়ে ডিসকাশন করে ফেললেই হবে।
একটা পিসিও রাখবা, তখন আমরা তো এখন মর্নিং সেশন রেগুলারলি করতেছি। মর্নিং সেশনে পিসিও নিয়ে তোমাদের যা কোয়ারি থাকে ছোট ছোট করে কোশ্চেনগুলো তখন আপাতত লিখে রাখো, সেই সময় আমরা আবার ডিসকাশন করতে পারবো। আজকে তো টাইম শুরু হয়েছে, প্লাস হচ্ছে আবার এখন টাইমও পার হয়ে গেছে, আজান দিয়ে দিয়েছে তো। ঠিক আছে, এখন মনে শেষ করে দেওয়া যায়।
থ্যাঙ্কস ম্যাডাম।
পরে বলছো
অনেক বেশি বড় হয়ে গেছে আমারটা না?
অসুবিধা নাই।
আচ্ছা, এটা ইনফার্টিলিটি রিলেটেড তো।
জি ম্যাডাম। Thanks all our audience, and thanks ACI, and thanks our respected madams.
Thank you, Faria.
Thank you, Priyanka.
You are watching
Thank you.
Raj TV. You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.